Good morning, everyone. My topic for today's presentation is bariatric surgery and psychotropics, and my moderator is Dr. Sanjeevani ma'am. This is an overview of all of the topics that we will be going through together. First, we will talk that what is bariatric surgery. Then we will talk about bariatric surgery and psychiatry. Then we'll talk about the pharmacokinetic changes following bariatric surgery, the drug formulations, and finally about psychotropics and bariatric surgery. So first, what is bariatric surgery? Bariatric surgery, which is also referred to as weight loss surgery, refers to a group of surgical interventions which is designed to reduce body weight and improve obesity-related conditions. The common types of bariatric surgery include the following. First is gastric bypass, where the top part of the stomach is joined to the small intestine. Then is sleeve gastrectomy, where some of the stomach is removed. And earlier gastric banding was previously performed, but is no longer recommended. The criteria for bariatric surgery. First is the patient should have a body mass index of 40 or more, or a body mass index between 35 and 40, and an obesity-related condition that may improve if the person lost weight. Example, the patient has type 2 diabetes mellitus or hypertension. Second is the patient has attempted all other weight loss methods, including lifestyle change and pharmacotherapies, but has not lost significant weight. And the patient agrees to long-term follow-up after surgery, example, making healthy lifestyle changes and attending regular checkups. In the general population, bariatric surgery is associated with both weight loss and remission of diabetes mellitus in individuals living with obesity. And while there are still limited data in patients with schizophrenia, growing evidence suggests that bariatric surgery may improve short-term weight status among patients with bipolar disorder to a comparable degree with individuals in the general population. Now we talk about bariatric surgery and psychiatry. Now, in a meta-analysis of 52 studies, the three most common individual psychiatric illnesses in candidates undergoing bariatric surgery were depression in around 19%, binge eating disorder in 17%, and anxiety in 12%. Moreover, 15% of patients reported a history of suicidal ideation before bariatric surgery. And although pre-surgery psychiatric disorders have not been associated with worse weight loss outcomes, post-operative psychiatric exacerbation appears to be linked to worse weight loss outcomes. Bariatric surgery can also be associated with clinically important changes in drug pharmacokinetics, although it is difficult to predict how psychotropics will be effective because of inter-individual differences and limited data. Current literature has shown improved long-term depression outcomes among bariatric surgery patients, and similarly, studies have also shown long-term improvements in anxiety severity, although it is a smaller scale reduction. Now, pharmacokinetic changes following bariatric surgery. Now, all procedures may alter the following. First is tablet disintegration and dissolution times via changes in gastric pH and mixing. The rate of absorption via changes in gastric emptying rate. Drug distribution via loss of adipose tissue, especially lipid-soluble drugs, and altered protein binding. And drug metabolism owing to improvements in hepatic function after weight loss. Then drug excretion via changes in renal function after weight loss. Then malabsorptive surgical procedures may further lead to the following. There can be decreased area for drug absorption, that is reduced functional intestinal length, altered lipophilic drug solubilization because of bypassing of proximal small intestine bile salts, and reduced intestinal wall drug metabolism via decreased intestinal length. Now, drug formulations. Any drug formulation that prolongs drug disintegration and dissolution can potentially impair drug absorption following bariatric surgery. Switching to immediate release formulations before surgery is generally recommended. Orodispersible and liquid preparations do not go through a disintegration phase and may be preferred if reduced absorption from solid tablets is suspected. And very large tablets, example over 10 mm in diameter, they should be avoided as passage may be impeded by restrictive procedures. Now we talk about antidepressants and bariatric surgery. The current evidence suggests that antidepressant absorption is reduced after surgery. Those studies are mostly limited to SSRIs after gastric bypass. There are signs of reduced absorption. It may include the rapid development of discontinuation symptoms and later loss of efficacy. Patients require close monitoring as those at risk of reduced absorption cannot be reliably predicted. The risk of gastric bleeds with bariatric surgery will probably be increased by serotonergic antidepressants. Now, this is a table which shows the drug and the specific evidence and considerations which should be seen. In SSRIs, the evidence demonstrates that plasma levels may be significantly reduced following gastric bypass, and malabsorption has been implicated in cases of discontinuation symptoms and loss of efficacy. In SNRIs, duloxetine levels are 42% lower after gastric bypass compared with matched controls. And the absorption of venlafaxine capsules, it seems not to be altered by gastric bypass. In mirtazapine, increased appetite and weight gain are possible and has been used successfully for non-mechanical vomiting after gastric bypass. And in tricyclic antidepressants, single case report suggests therapeutic plasma levels can be achieved within usual dose range after gastric bypass, and plasma levels may be increased after significant weight loss, and we should consider monitoring levels and reducing dose. Now, antipsychotics in bariatric surgery. Antipsychotics are not well studied in bariatric surgery, and the data are limited to case reports or theoretical concerns. Now, depot antipsychotics avoid the risk of reduced absorption after surgery, and given the limited data on pharmacokinetic changes after surgery and inter-individual variability, routinely switching to depot antipsychotics before surgery may not be justified. However, depot preparations remain an option for those stabilized on treatment or in patients demonstrating signs of reduced bioavailability after surgery. Now, bariatric surgery may contribute additional cardiac stressors to patients with QT prolongation, hence ECG monitoring before surgery is recommended. This is a table which shows the drug and the specific evidence and considerations. Esanapine is primarily absorbed via oral mucosa, so problems after bariatric surgery are not expected. One case report of successful use after gastric bypass surgery is there. In cariprazine, no data is available on absorption after bariatric surgery, and we should follow the general recommendations. In clozapine, there are 2 case reports of relapse after gastric bypass surgery. So we should take drug plasma levels before surgery and regularly monitor the patient after. Constipation is common after surgery, so there should be close monitoring and active treatment. And we should check smoking status because quitting before surgery is encouraged, and we should adjust the dose accordingly. And in haloperidol, there's a single case report which suggests level after gastric bypass are similar to those generally reported in literature. Lurasidone, there is a risk of reduced absorption with reduced or inconsistent calorific intake perioperatively. So it must be taken with food for absorption. There is 1 case report of relapse following bariatric surgery, significant reduction bioavailability and peak serum concentration. 1 case report post gastric bypass showed significant reduction in plasma concentration with no worsening of psychotic symptoms, and we should consider switching to alternatives before surgery. Olanzapine, there is evidence of weight gain post bariatric surgery and conflicting information on site of absorption. We should follow general recommendations. In quetiapine may be absorbed via the stomach and duodenum. So we should monitor mental state, and switching to immediate release preparations and dividing doses more than equal to 300 mg has been recommended. In risperidone, consider switching stable patients to an equivalent dose of paliperidone long-acting injection. And risperidone long-acting injectable has also been successfully used when oral treatment was not tolerated after bariatric surgery. Ziprasidone must be taken with food for absorption. The risk of reduced absorption with reduced or inconsistent calorific intake perioperatively, and consider switching to alternatives before surgery. Now, mood stabilizers in bariatric surgery. First is carbamazepine. There is a single case report of agranulocytosis possibly related to increased plasma levels after sleeve gastrectomy. Lamotrigine, possibly absorbed from the stomach and proximal small intestine, monitor for loss of efficacy. And lithium, there are cases of lithium toxicity following gastric bypass surgery and sleeve gastrectomy. Switch to an equivalent dose of lithium citrate solution. In the preoperative period, plasma levels may be affected by prescribed dietary changes, and in the postoperative period, plasma levels may be affected by malabsorption. It's mainly absorbed by intestine, fluid shifts, and weight loss. Lithium clearance is increased in obesity. And in valproate, there's a single case report which suggests that absorption may be significantly reduced after malabsorptive procedures. There is no data on restrictive procedures. Dose reductions may be necessary after weight loss. Switch to liquid preparation before surgery, or if malabsorption is suspected, on controlled release or enteric coated tablets. Baseline plasma valproate levels and LFTs with ongoing monitoring is recommended. Monitor for clinical signs of poor tolerability, possibly occurring at normal plasma levels. Now we'll talk about lithium around the time of bariatric surgery. The following guidance is based on available case reports and expert opinion. Monitor lithium plasma levels weekly during preoperative phase and for 6 weeks post-surgery, as fluid intake gradually increases, 2 weekly for 6 months and monthly thereafter. Resume usual lithium monitoring 1 year post-bariatric surgery. If plasma levels increase by more than 25% or approach 1.2 millimole per liter, consider decreasing lithium dose. Withhold lithium if signs of toxicity are present and review the dose. Monitor mental state periodically using formal rating scales if possible, and encourage patient to drink 2.5 to 3 liters of fluid per day in the preoperative phase, including liquid meal replacement. Now, in benzodiazepines, the bioavailability is probably unaffected. There's a shorter time to peak concentration. Methadone is substantial increase in bioavailability after sleeve gastrectomy in one case report, possibly related increased rate of gastric emptying, and consider plasma level and QT monitoring. Methylphenidate, conflicting limited data. One case report of reduced treatment efficacy after gastric bypass that resolved after switching to transdermal patch, suggesting reduced oral bioavailability, and another report signs of toxicity. Now, the general recommendations for prescribing in bariatric surgery. Before surgery, do not routinely increase the dose. Clinically relevant malabsorption cannot be reliably predicted. Assess mental state before surgery and consider measuring baseline drug plasma levels. Switch modified release or enteric coated preparations to immediate release tablets or to liquid preparations. After surgery, around 0 to 6 weeks after surgery, closely monitor for signs of adverse effects and drug malabsorption, that is symptom de-emergence and or discontinuation symptoms. Regularly monitor drug plasma levels if clinically indicated. If malabsorption is suspected, consider the recommended strategies, and if medication toxicity is suspected, withhold and reassess the dose. After surgery, more than 6 weeks after, continue regular monitoring for the first year post-operatively. Although frequency can be reduced if stable, monitor for an increase in adverse effects, especially if doses were increased in the acute post-operative period, and consider returning to pre-surgical treatment regimen after 1 hour, depending on the clinical history. Now, the general management strategies for patients demonstrating the signs of reduced bioavailability consider non-oral routes of administration where available. Dividing doses may improve malabsorption related to a reduced stomach capacity after surgery, and switching modified, prolonged, or delayed release to immediate release formulations. Switching solid tablets to liquid or orodispersible preparations to bypass disintegration phase, switching large tablets to smaller ones, and in cases where doses have been increased to account for reduced bioavailability, monitor for emergent adverse effects as bioavailability may normalize over time. Now, psychotropics with the risk of weight gain after bariatric surgery. It is estimated that 10 to 20% of patients retain a significant amount of weight after bariatric surgery. There is no information on how psychotropics associated with weight gain affect outcomes after surgery, but high-risk drugs should probably be avoided. Patients' individual clinical circumstances should be considered, especially if he is stable on treatment and at a high degree of relapse, and as there is evidence that uncontrolled mental illness is a risk factor for weight regain. Alcohol gastric bypass surgery is associated with accelerated alcohol absorption, higher maximum alcohol concentrations, and a longer time to elimination. There is also an increased risk of alcohol misuse disorders after gastric bypass, and data are less clear for sleeve gastrectomy, and there is no evidence that gastric banding leads to any changes. Now, in practice, many patients may not require significant changes to drug treatment after surgery, and relapse of symptoms after surgery may not be related to altered drug pharmacokinetics. And although improvements in mental health are to be anticipated, deterioration can also occur due to a range of factors, including unmet weight loss expectations, poor tolerability, and dissatisfaction after surgical treatment. These are my references.
Suicides.
I could not find any information on that. So before surgery, so there are risk of suicidal ideation and suffocations.
Any studies increase of suicide rate? Any form of actual these surgeons, do they recommend mandatory psychiatric screening for surgery?
So I could not find any article on that. So in all the articles I read. So they talk that post-bariatric surgery, the multivitamins, the nutrients, they have to be very closely monitored.
But definitely post-surgery, there is a phase of psychiatric.
Yes.
Sequelae.
Yes.
And they recommend depots.
Yes, sir. So post-surgery.
Which can be planned before the
Yes.
The patient is going. Because the elective post. You can actually switch to depots much earlier. It only can be carried most of it.
Sir, it was written that it depends on the patient. That if you want to switch him to a long-acting injectable.
Long before I had a patient from Turkey, bipolar disorder, had a pediatric surgery. He was sustained release and discontinuous bupropion because bupropion there's no preparation available, which is not extended release. To discontinue that lithium, we have to take it to an immediate release preparation. And he settled down. one of the person known in my family who committed suicide through bariatric surgery. So the expectations of weight loss. So he couldn't eat, so ultimately took cyanide. They thought that this was greatly obese. So I do some insulin. So that went off. Antihypertensive is also taken off. Subsequently, suddenly comes. Lost weight, his health improved, diabetic drugs, antihypertensive, all was stopped. Everything became fine. But we gradually, because of some event, and then that couldn't be resolved with antidepressant, and that person committed suicide. And one of the patients also committed suicide. So I was asking, is there any data the bariatric surgery associated with suicide? Bariatric surgery, that instance. So it is something which is probably yes. So maybe this was a trigger. We need more data.
So because there is long-term depression, so उसमें improvement आया.
It is like many people commit suicide, probably few must have had bariatric surgery. But government of bariatric surgery would increase the rates of suicide compared to general population. Then it becomes a risk factor. But we need more data. हमारे यहाँ है information for bariatric surgery. Usually it is gastrosurgeons. But gastrosurgeon, one gastrosurgeon, he was female. He was not doing bariatrics. Otherwise, it's worth enough to follow and see this. Which is more common now, sleeve surgeries or they just bypass the stuff?
So gastric bypass surgery is more common.
So overall, I feel that sustained release for patients should be okay. Secondly, syrups.
Yes, and smaller tablets.
Venlafaxine was saying is safe, but generally they are also hypertensive. Generally, bariatric children are very young. Generally, they have generally won't give them.
Contraceptives by this after this bypass to patients who are in the
Failure. Any drug which availability increases. The hormone drugs availability will increase. The lithium is not because it is not like the pain. That is one of the reasons. So water soluble drug, most of the psychotropics are limited. Really availability because of the malabsorption, it will not be absorbed. I think lithium is exception. You know, one of the centers actually made this a law in Delhi. They'll actually go for very strict screening of psychiatrists, bariatrics. Because ultimately what happens if they are on some psychotropics, post surgery results in nothing. They'll only gain weight. Yes. No?
Or if the patient is on antidepressants and is going to undergo pediatric surgery, so usually the anesthesia clearance, I think they will only say that since the patient is on antidepressants, suppose psychiatric clearance. Usually anesthesia is-
But ideally, because there are no patients, ideally any patient who is bariatric should have a screen. Because once they start to gain weight, it's a very catastrophic case. They've lost weight, they're very happy, and then once they start gaining weight, which most of them do at times, so then they actually go into a lot of distress. I think she's presented well. More pictures were. This is a very interesting topic. I think that we have done justice to it. We covered each section. The pictures were taken from mostly were actually written, could have copied and pasted from the little paraphrasing. Otherwise, the pictures will copyright. Thank you.